Today we're diving into a question from one of my patients. They always bring me the best questions. This patient was heading out on vacation, had access to this pond that apparently had tested positive for E. coli. So he's wondering, should I be worried about this? Can I still go enjoy my paddleboard? Or is this a total no-go zone? And he sends me this question. And the question's interesting on multiple levels. First off, I'm sitting there thinking do I even know the answer? I mean, I have a vague idea that this might be a high-risk situation, but how accurate is that? I have no idea where that impression came from. I can't cite a study. I certainly can't quantify the risk for him. And this brings us to a broader kind of intriguing social issue. As a society, we're not great at publishing or accessing quantitative risk information. I really find it tough to dig up this particular category of data. Public health organizations tend to give these blanket, do not do this or do this kind of statements, and communicating risk isn't easy. There's a difference between a one-time risk and the risk of doing something as a habit every day or every month or once a year. And then where's the line between things we think we'll just do once but actually end up doing habitually, or things we keep saying we'll quit but we don't? As a brutal example, I always think of Russian roulette. We can quantify the risk of death doing it once, but the risk is way higher if you play every day, even though the risk of each individual event doesn't change. For instance, prescribing antibiotic comes with its risks, like potentially causing C. diff diarrhea, or say, prescribing a Z-Pak might lead to cardiac arrhythmia or even sudden death from cardiac arrest. But where are the numbers? How often do these things happen? It's one thing to have seen these outcomes in clinical practice, but another one to have hard data. And how do we quantify the risk of doing it once versus the risk of taking an antibiotic 4 times a year, every year? One issue is that risk data is hard to obtain ethically. Coming back to my patient's question, no one will ever do a definitive study to test this risk. You'd have to grab 1,000 random people and assign 500 of them to get a milliliter of pure water and 500 of them to get a milliliter of contaminated water and compare the rates of diarrheal illness. But we also know that models are usually flawed and erroneous because they can't account for all the factors. Nonetheless, establishing microbiological risks is a little bit more standardized. There is what we call Quantitative Microbial Risk Assessment, or QMRA, and the standard 4 steps of that are hazard identification, exposure assessment, dose response analysis, and risk characterization. Hazard identification in this case is E. coli. Exposure assessment, trying to figure out what is the likelihood that this patient will be exposed if he's going to be swimming in a pond that's contaminated. He might swallow water. Dose response analysis, how much E. coli does it take to cause an infection? We'll get to a paper on that in a second. And then risk characterization. That's the final thing that the patient is asking me for, is how much risk is here. So now we want to figure out each of the 4 steps, and the 2 papers I've found that are most relevant to this are these: Volume 1, Volume 2 of Risk-Based Site-Specific Recreational Water Quality Guidelines by the Water Research Commission out of South Africa. The first volume is actually quite interesting because it's a great overview of the concept of risk and risk assessment. Number 1, what could go wrong? How likely is it that it'll happen? And if it does happen, what are the consequences? And they point out correctly that these first 3 steps are a mathematical question. However, the assessment of whether a level of risk is acceptable or unacceptable is not a mathematical question, but a value-based question. So starting with exposure assessment, what's interesting here is that there are actually studies evaluating how much water on average tends to be swallowed during various activities. So during recreational swimming, the average is 25 mLs per hour, and during canoeing, it's only down to 4 mLs per hour. So using something like board sailing as a proxy for paddleboarding, because they're pretty similar, you end up with a rate of about 4 mLs per hour. So that would be the exposure assessment for the QMRA. If he goes paddleboarding for about an hour, risk is on average he'll swallow about 4 mLs of water. And then the question is, well, how much E. coli does it take to cause a problem? In this Health Canada study, 2012, the rates of illness were not significant until E. coli concentration approached or exceeded 200 E. coli per 100 ml. So that's our dose response, is that if you are over 200 per 100 ml, then swimmers in those waters were at an increased risk. Depending on the level of contamination and the amount of water ingested, the risk could vary considerably, and the variance might be nonlinear, making it difficult to model accurately. I found this study on waterborne pathogens in a wastewater treatment plant, which created a model to estimate the infection probability from E. coli exposure. This study was looking at a wastewater treatment plant, and they were trying to say, well, what's the risk of an accidental exposure? According to this model, even a one-off consumption of 1 milliliter of contaminated water could pose a 23.8% risk. That's huge! And it gets even more concerning when we consider using such water regularly for recreational or domestic purposes, with risks shooting up between 55 and 92.9%. To add to the complexity, the risk of infection changes with the age, health, and immune status of the patient, as well as other factors. And that's what makes risk assessment difficult. People need risk information to make smart choices, but those who could provide it are often worried about the legal implications. So we end up with broad, vague, dogmatic advisories that reflect a combination of fundamental uncertainty, legal concerns, and political or economic incentives. Just look at the pharmaceutical company data. Publishing accurate risk information just isn't in their best interests. Long after ibuprofen came on the market, we found out that it increases the risk of heart attacks. Fluoroquinolone antibiotics had been in use for decades before studies proved that they increased the risk of tendon rupture. And the battle to get real estimates on the risk of statins for muscle pain and diabetes and accurate representations of their benefits was long and in some ways is still ongoing. So what's the takeaway from all this? Well, it's that there's a significant gap in our health communication. There's a need for a more nuanced approach to risk information and risk communication. We need to develop a common language around risk, from riding a motorcycle to taking an antibiotic. And we need that language to avoid sensationalism, to have a standard format like the paling risk perspective, which I love, and some standard way to quantify and communicate not just one-time risk, but habitual risks at different frequencies, so we can tell the difference in risk between riding a motorcycle one time and buying a motorcycle to ride every day as your primary transport. It's complicated, but we live in a complicated world. As for my patient, I recommended that he leave the paddleboard behind and enjoy the pond's beauty from the outside. Maybe I deprived him of a fun time, or maybe I fell prey to my subconscious fear of malpractice or legal risks. If you're curious to know more about how health information can be slanted, check out this video.